introduction, thank you, Dr. Dumois. To Dr. Juan Dumois and Dr. Adriana Cadilla. Dr. Dumois is from Johns Hopkins Children's Hospital in St. Petersburg. Dr. Cadilla is from Nemours Children's Hospital here in Orlando. And they have graciously accepted our request for them to help facilitate this work group, and we very much appreciate that. The goals are basically just to arrive at 2 or 3 objectives that this group will work on from now until our next summit in the areas of early detection and treatment. So this is a work group, and we appreciate your help very much. I have clipboards in the back. If anybody would like those, just raise your hand. I have some paper and pens for everyone. And this is a brainstorming session, and I know it's gonna wind up with some great successes. So thank you very much.
Thanks, Jack. I'll just come sit up here. I'd also want to introduce Dr. Vincent Valente, who's an emergency medicine physician here at Florida Hospital. And so our panel of 3, we're going to try to lead you through the discussion of what the key points are going to be here for diagnosis and treatment and how to improve the way that's done here in the medical setting. I've got a few slides here that I pulled from a lecture I have on encephalitis. And I don't think we'll have to go into these in any detail because we've heard some very great presentations this morning. Next slide, please. Next slide. I have no relevant conflicts of interest to declare. We had to put that in there. Next. Let's get this. This is not new information. Next slide, please. Next slide. Here's some epidemiology that we saw in the CDC presentation from Dr. Cope, that it's not just in southern states, but northern states may also see this. So in our plans for where we should disseminate the information, it may not just be, our goal may not just be Florida or other southern states, but perhaps nationwide. I even found a case report from Canada. Next slide, please. These are some counties where through 2013 cases have been reported, all the way up into almost into the panhandle. Next slide. Now, diagnosis, we'll just spend a minute here. And we heard an excellent presentation from Dr. Ali about diagnosis. And I just wanted to pinpoint some of the ones that could potentially be done in a hospital setting. The main one, the first point, is direct visualization, where in the spinal fluid, we can look for the amoeba on a slide that's gently warmed under the microscope. We can also do a test that doesn't look at the fresh spinal fluid, looking for the amoeba moving around. It's a stain called the Giemsa-Wright stain. So in that, it's a fixed slide, so there are no living organisms, and one has to identify the amoeba by its appearance, and we saw some very nice pictures of those purple amoeboid cells that have an oval shape. The PCR, or polymerase chain reaction, is the rapid, most sensitive test we have. Unfortunately, most hospitals don't have that available. And I was unable to find, searching over the last couple of days, any commercially available test that a hospital could purchase and start implementing in-house. So PCR detection is usually still done by sending a specimen to the Centers for Disease Control or maybe a state lab. There's amoeba culture, where you can get a petri dish and put a bunch of E. coli across the plate, inoculate some CSF onto there, and if they're amoeba, over the course of a week, you'll see little trails of where the amoeba had crawled across the plate, eating bacteria along the way. But that's not a rapid test, and it's something that most hospital labs may have never done. I did put in here calling the CDC Emergency Operations Center. As was mentioned by Dr. Cope, they want us to call, even if it's just for advice, guiding us in how to manage the case, diagnosis, and treatment. Next slide. Therapy, we've heard it many times this morning. Early diagnosis and treatment is critical. We need to monitor and manage cerebral edema, and some of the ways that is done are listed there. And then I've listed the antibiotics that are used. The doses are not important for our discussion, including miltefosine, which we will discuss a little bit more on the agenda today, because historically that's been a drug relatively difficult to get, because we had to call Atlanta, the CDC would ship it overnight, and there was that delay in getting the drug. That's gotten to be a little bit better. Next slide. Okay, good. So let's start on our agenda to talk about early detection. There are a lot of children who present with symptoms of amoebic encephalitis but don't have amoebic encephalitis, because as you heard from Dr. Jordan, it presents like any case of meningitis. So we have to suspect the possibility of amoebic encephalitis if the patient had the particular exposure to fresh water, not salt water, and it's not any fresh water. So if they went to the YMCA and went swimming in the pool that's so chlorinated you can smell the chlorine from across the hall, that's not a risk factor. But an unchlorinated water exposure or a poorly chlorinated water exposure, the pool that's kind of neglected, that's a potential source. Tap water, where the chlorine may have degraded over time because it ran through a pipe across the desert for 1.5 miles, as we heard earlier, that may be a potential source. The question then is, how do we get medical personnel to think about asking that question? Recently, we were discussing a case when I was teaching some of our resident doctors in training of a child who presented with a change in their mental status, and no one had asked a question about freshwater exposure. So it's still an issue that needs to be addressed, that they're not thinking of asking that question, the social history question of the water exposure. So we can open it up for discussion now. What ideas people in the audience have for how can we remind clinicians, whether it's the triage nurse in the ER or the hospitalist who has just received a patient in transfer from another hospital, the infectious disease doctor who is asked to come see a patient with meningitis, how do we get them to remember to ask that question? Did you all want to say anything else about that?
Looking at this infection, I look at it as an ED or a primary care infection to own, in a sense, because we see this patient initially when they walk into the door, and that is the ED is the front door of the hospital. It's the front line defense, but also I look at it as the family practitioner is also that, the pediatrician is also that, the urgent care doctor is that. If we're able to disseminate this information out and have that added to the list of questions that are part of their triage protocol, that will owe, and each line of defense, one person might ask that question. So the more people that know about this, the more people that understand this infection and the risk, because it's a time-sensitive disease. That's the key thing behind this. So it's getting not just the emergency department, but also the other clinicians in the community understanding that, and then sending them to the emergency department with that information just expedites the care. And that was my take on that in a sense. So we can also go back into once that thought and that suspicion is notified, but it's trying to get that question out. And we were talking earlier, Dr. Dumois and I, the exact question to put on that questionnaire is very, very important. People, we were just talking about earlier, fresh water exposure could be anything to people. They don't understand what that might mean. So it's getting that right question to be put into the list of questions that go on through the triage process in your family doctor's office, your pediatrician doctor, the urgent care office, the emergency department, in order to initiate that discussion amongst the caregivers once that patient comes through the doors. So that's something I like to bring forth to the group here today, to see if we can come up with probably the right terminology of that question. I think is very, very important, Because without that, nothing else gets done, and it can potentially be missed, and that's where we have some issues.
And I'll add, in the review of cases that had been done up to 2013, they actually noted that about a quarter of the patients who initially presented and ended up having PAM were actually sent home initially, because when you present, again, that's where we have to have a high index of suspicion, and it's going to be key for us to figure out the right questions to ask. A headache, how many times does a patient come in the ED with a headache? It's migraines. We give cocktails. So what in the history is what's going to trigger us to talk about this? So, recently with the Ebola outbreak, there were specific questions that were being asked, not just by the physicians, but it was being asked at triage. So that was something that was talked about earlier. Do we need to ask certain questions as the patient is presenting to the hospital? The wording is going to be very important. And also, as physicians and healthcare personnel, we also need to be cautious about alert fatigue. This is something we talk about a lot. Those of you who work with this, especially now in the EMR setting, how many alerts we get a day, and I'm guilty of ignoring some of those just because there's so many of them. So we need to figure out the best way, where in the triage is it that we're going to be asking these questions so that the consequential steps all occur in the right way. Anybody have anything they'd like to add, any experiences, any suggestions?
I'd just like to add, so one of the things that Dr. Dumois and I have talked about in the past is also the fact that as you move through the continuum of care, right? So you come in to the emergency room, what's very challenging is once the diagnosis is done, no one's really going back to question, did we get the right diagnosis, right? So in Jordan's case, when he came through the ED and we found out that he had viral meningitis, or that was the diagnosis, when we were then transported to the children's hospital, those questions never came up either. So I think it's important if that training is out there, that maybe at least somewhere along that care pathway, that then there'd be an alert that might then trigger. And I guess the other comment I would have is the symptoms are very specific. We've talked to many of the families around the headache, the stiff neck, the vomiting, the fever, and the CDC puts a lot of that in their documentation. So I think, again, to your point, asking the right questions, looking at, all the symptoms that they have, and then being able to ask that one question. And I think the other comment earlier was also around, have you been out of country? That's another one, or your travel. I think could be a really big question, because quite honestly, that's what drove us into the hospital so early in Jordan's case, was because we had been out of country. So I think just really good input and a lot of the same thoughts and feedback. Thank you.
Sure. Okay.
Us. So one thing I would suggest too is educating the EMS departments. They have alerts on their computer and stimulate them to ask that question maybe early. Yes. I also run the transport education, so we can see if we can start adding that to our system, so that even if we go to pick up a child who's in the land or wherever and they've not been asked that, at least we ask it as soon as we hit the floor.
That's an excellent point. I did that on the list of that. EMS is one of our primary, as our first responders. So when they show up at a house, when they ask them those questions also. So that also should be added to the list of where do we need to educate and disseminate this information to. Like I said, the alert fatigue at the hospital is kind of overwhelming. I probably in a day have hundreds of alerts go through a day, so that's why generating this early in the patient encounter is important. Yes.
I was just thinking along the lines of
That's an excellent point. Adding posters or something to the effect of alert to the patient if you have these kind of symptoms. If you have any fresh water or unchlorinated water exposure, please notify the nurse too.
And that CDC fact sheet provides that information on one page. I think the problem that arises from a pediatrician's office point of view is that everybody with a cause wants their poster up in the pediatrician's office.
Yeah, sure.
And so how likely is it that the pediatrician is going to put up the PAM notification but not the ADHD one or the all the other possible important things that we underdiagnose. So I think there may be a role for that somewhere. I'm just not sure how well to implement it, how well it would be implemented.
Sure.
Yeah, Dr. Gumpf.
That's my son's photo up there. Lost my son 7 years ago to this, and I was one of the people my wife spoke about who grew up in Florida and was always in the lakes and couldn't believe this could happen to my son. It's very hard for me to talk about this, but as a pediatric hospitalist, summer is enterovirus meningitis season as well. And looking at the spinal fluid studies of Sebastian, I cringed because his initial spinal fluid studies were really unremarkable. And actually, I see dozens of kids every summer with meningitis from a virus. And some of them have a history of going in the lakes because Polk County, Florida is full of lakes and kids are out there tubing and water skiing and doing all kinds of stuff every day. So from a practical standpoint, this is a difficult thing to consider because even if you get that history that they were in the lake and everything looks like viral meningitis, from a practical standpoint, what do you do as a community pediatrician or hospitalist where you have lakes all over and dozens of kids going in the lake and those same kids are coming in with viral meningitis? So I guess I know the answer, but the answer is probably that we need PCR testing available at these hospitals that are in areas where lakes are everywhere. You know, Orlando, lakes are everywhere. And that's probably the answer, but right now we don't have that available, and it makes it difficult for me as a pediatrician, kind of on the front line, seeing all the routine meningitis, to think how we're going to decide whether we should send a test to the CDC or take that next step, because waiting even 24 hours to see what happens with what you think is viral meningitis is going to be too long for Pam. Kind of a question and a statement.
That brings up a really good point that I thought about earlier this week when I was having this sort of a discussion with one of my colleagues over in St. Petersburg. She's also in infectious diseases, and she brought up that practical point. Every child who comes in with a headache, are we going to have to put in an intracranial pressure monitoring device? No. But how do we prioritize who gets tested? And so in our chat, what we came up with is that at least for the child who's presenting with symptoms, more than just a headache, but it looks more like it's bacterial meningitis, by symptoms alone, that's where it's going to be important to consider the diagnosis of PAM and asking for that exposure to unchlorinated water. In most cases, we're going to plan to do a lumbar puncture, and I think that's why now here at Florida Hospital, they have in the electronic medical record, when a doctor is going to order tests on spinal fluid, an alert shows up asking, has the patient had any freshwater exposure? And I haven't seen how it works, but I assume that if it's yes, then there's a prompt to Here's the person who can comment on that.
He's the one that developed this.
About the alert system?
The clinical decision tool that you guys just.
So, after Jordan, I felt really bad that I felt that I missed the diagnosis. And the reason is because we always relied, what we get from the lab back, and the lab came as negative. So I say, if it's negative, then, it's not there. So I have to think in other things. So after we met the first time in the conference room, it has to be something better that allow us to be sure that the sample that we pay more attention to the samples, basically. So we came to the idea to have an alert system, and every time that a physician orders a CSF test, it will ask you to provide information whether or not it was water exposure or not. And we hope that when the physician or the nurse practitioner or the physician assistant see the alert, if they didn't ask, they go back to the room. They are not just going to fill the spaces, yes or no. They actually go back to the room if they didn't ask and ask about the exposure. And the exposure has to be, not just lakes. In the alert, in the warning, we put, unchlorinated water, springs, ponds, lakes. So not just lakes, because there are many just lakes for bodies of water. If the answer is yes, then it sends an automatic communication order to the lab tech and the pathologist to say, this patient is coming for meningitis. We're sending a CSF and there is water exposure. So that person pays more attention to the sample and takes more time to look at the sample and try to see if they see anything that is concerning for amoeba or not. So that's the reason for the alert. It's been going through many phases. Initially we were kind of reflecting it to an order set to do an amoeba culture, which ended up doing the wet prep, which is what we do to check the sample. That was causing a lot of algorithm problems within this electronic medical record. So that's why we created the communication system instead of the actual order set. But it's the same thing, that are going to still look for it. The other thing that is different is, after Jordan case, the lab techs are getting more training and more training to be sure that they are looking. And now every single sample they get for CSF, they are looking regardless if we tell them there is exposure history or not. But I think that provided that information will make them more aware to actually look for that.
If the clinician ordering the CSF test clicks yes on water exposure, is there any suggestion to call infectious disease or critical care?
Not in the protocol until we have the confirmation back from the lab.
Okay.
Now, we don't have anything automatic to call the infectious diseases or the ICU yet. We were talking about yesterday whether or not we should create an automatic kind of alert system to call the ICU and the ID physician on call. So far it's just alerts the lab to take a more carefully look at the sample.
Thank you. You'll quickly see I'm not a medical person, so a couple of quick questions to that, Dr. Jordan. So I know when you were first putting in the alert that it was my understanding it would be for both bacterial and viral meningitis. Can you clarify, is it for both or just bacterial?
When we order a CSF, we don't make a differentiation if we're looking for bacteria, viral, aseptic, like cancer. It's just a CSF sample.
Okay.
So
awesome.
there is no. So we don't mislead anyone. Going for bacteria, looking for virus.
Thank you.
It's
really
it's a plain CSF sample,
Okay.
and then in that CSF sample, then they will look for it.
And do you know in Sebastian's case, was the CSF fluid heated, or was the lab tech just able to actually clearly identify?
He's right behind you.
It was not heated, it was a direct wet mouth.
Oh, okay, thank you.
Now, Sheila, if we tell you that is water exposure, you will heat the sample longer and you will pay more attention to it. That's right.
We have a whole technique within our procedure for handling body fluids. The thing about the amoeba, in my case, when I looked at it, if I had not looked at it long enough, I would not have seen that super hard. But if we have a suspected case, we can literally heat the slide, and the heat actually causes the amoeba to become more mobile, and we can see the movement.
And that's the idea of the alert. So they know and they will do it and will they pay more attention to it.
Last year, Dr. Dumois talked about she thought that you could put the CSF fluid in water, and by doing that, you would actually see. I'm just curious if any of the lab may have the question of what the lab techs would think about.
She might answer that.
The question had to do with a speaker last year suggested that you might have better sensitivity in seeing the amoeba if the CSF specimen was supplemented with some water on the slide. Had anyone in the lab heard of that? No.
You don't add anything to the CSF fluid at all at this moment. Okay, either that you look at it longer, if you think there's something we'll warm it up if you need to, the CSF directly, so not add extra water.
Because what happens when you look at it long enough, the light from the microscope warms up the slide and gets it moving more. But if you gently warm it first, you might see it sooner. Yes, Dr. Gahn?
A couple of things. One is I can tell you where I work, it's the busiest emergency room in the state of Florida. And when my son was there and had the CSF looked at, my partner called the lab, called microbiology and said, look, he was in the lake last weekend. Right? There was one person in the whole department who had seen one amoeba like 10 years before. And they worked on his specimen and worked on it and worked on it, and eventually were fooled into thinking they saw gram-negative diplococcide. And that's what we went with on the treatment of my son, is that he had bacterial meningitis after that. And that was the wrong diagnosis. So my point is, we have large community hospital centers like Lakeland Regional, and we need to have a way to get your knowledge to those places.
And I was just going to say, so also helping is, even though we don't have PCR per se for the amoeba right now, we have those meningitic panels that look for a lot of the viruses and bacteria. So something we were talking about was, if we see any pleocytosis at all, we get our meningitic panel anyways, it'll default to it. If that comes back negative, we need to really go back and look again at that CSF sample. So, there's still time there because it takes about an hour to get the meningitic panel in our institution. So, but at least having that negative really is going to prompt us to look further.
So that brings up a point I had added to our agenda for discussion, and I'm glad you brought it up, is educating lab personnel. Any other comments on the need to educate lab personnel? Yes.
I'm a lab tech, so I was just thinking it might not work as far as a national level, but in Florida, there's at least 2 courses that are mandatory for us to take when we're renewing our licensure. So maybe in the state of Florida, it would be something to consider to have that as a mandatory CME training before we can renew our licenses.
Does anyone know how you get CME requirements changed here? Is it the Board of Medicine? I know Board of Medicine is for doctors. I don't think Department of Health monitors licensure. I think that might be the Department of Business and Professional Regulation.
For nursing, they do, along with the Board of Nursing. So
they do.
Send out what's required. They help decide it. So we can throw nurses in there as well. Paramedics have to research their license. You can make it a requirement for anybody who needs to relicense or re-up.
Yes, comment back here.
Mine was more like a suggestion, like to the nurses or the clinicians that ask the question about the water exposure, to be specific, like explain to the patient, like rivers, ponds, lakes, springs, because sometimes the patients will be foreigners, they don't know what fresh water is. So I think that will help, finding exactly where the patient was before.
Yeah, that's why we put it like fresh water, and then we divide it on unchlorinated, exposures. We have the ponds, we have the lakes, we have the river, we put the springs. We try to put as much as we think that is probably we mean some. We try to put as much as we think is water exposure there.
Even the use of a neti pot type nasal irrigation.
We didn't put that.
No, you didn't do that one? And in that, with the neti pot though, it's only if you use tap water. But the instructions for the neti pot say use distilled water. If you do that, you don't have to worry about the amoeba. If you use tap water, then there's a risk.
My coming back to the laboratory evaluation, what about children who have horrible spinal fluid with thousands of white blood cells on presentation? How easy is it going to be to do a wet crack?
So the question was, if the spinal fluid has tons of white blood cells in it, will it be harder to do a wet prep looking for amoeba? I imagine it might be, and that might be where the Gimsa stain's better.
We also do a concentrated cytospin smear in conjunction with every cell count that we do, whether there's cells present or not. And that's where the stain forms of the tropes.
That's where you see the what?
The stain forms of the tropes.
And what do you stain the cytospin specimen with?
Bright stain. Same thing we do for CDC.
Okay, I think, okay. All right, yeah. Yeah, you should still see the amoeba.
Is that common practice throughout the country? Is that common, or is that only for Florida Hospital? Do you know?
I don't know if I can answer that. I mean, every institution that I work with.
Okay. I wasn't sure if that was just common.
When do you do the cytospin?
That's done always in conjunction with any cell count, whether there are cells present or not.
Oh, every CSF, whether it looks normal or not, you cytospin it.
Yeah, the difference is warming that cytospin.
Yeah.
That's what the key comes. Have at least 10 to 15 minutes of
We
heating.
also will concentrate the spinal fluid if we were alerted,
Mhm.
and to even concentrate on the wet prep to look for amoeba.
So that alert would be very helpful for you to okay.
Question in the back?
Hi, I'm Director of Nursing for the Department of Health, and I will follow up on the question about the CMEs. I'll have a direct line to Tallahassee, but I have a personal question. We have a saltwater pool. Should I be concerned?
If it's well salt, no, because salt converts to chlorine. So the chlorine comes from salt. So that's what, when you get chlorine, the bleach and all that, the salt plants that actually converts to chlorine. That's what the bleach comes from salt. So the idea of the salt in the pools, it will convert to chlorine, and your pool is basically chlorinated. Now, do you have to do the same testing if you have enough particles of chlorine per water? You cannot rely because it's salt, it's a salt system. I have the amount of chlorine particles that I need. So you still need to do the testing for chlorine to see if you're putting the enough amount of salt that you need. But the idea of the salt is that it converts to chlorine.
And my last point was that my previous hat was Director of Education for Adventist Health in California. And when we would attend summits like this, I would get a call from the medical staff because you guys are exhausted, but the triage nurses are your lifeline. And so we would focus on the education of that particular person, on that particular, intensive education. And as the doctor noticed and stated, with Ebola, you just ask, it just gets redundant. You ask the same questions. And that's what we have to do. It's just the practice. We have to change the way we think and use your Department of Education. That's what we're there for.
Comment here?
Yeah, I know we all talked about the beginning, when we go back to the beginning of sending water, springs, lakes, ponds, and anything like that. Through conversations with Steve and the depths that we had, even asking if somebody fell in a warm puddle, things like that, especially out here in Florida when we get our heavy rains and the water just sits there. Kids, and I think, and correct me if I'm wrong, I know Steve and I had a conversation that there was a young kid that got pushed in a puddle of water and he ended up getting the amoeba and passing away as well. So besides just asking about lakes, ponds, pools, unchlorinated pools, just any type of freshwater exposure. And we were just talking out there, the Dr. Cadilla, let's say jumping in a puddle and it splashes up. And I can't remember the doctor's name that handled the case just recently, Sebastian's case. Yeah, we were just talking out there and he said, yeah, just jumping up in a puddle in the water.
Well, there's also the case we saw of the kid using the slip and slide.
Yes.
So maybe what you're suggesting is that we ask the question in a way to say, did your child play in any kind of water?
Yeah.
And then you can delve into the likelihood of whether it was chlorinated or not. That's a good point.
Yes, it's like everybody's looking at the bigger.
I like that. Yeah, that's good. Comment here?
My name is Amanda Owner, the PICU educator, and I was actually the nurse that went up for rapid response the day before everyone. And a lot of the theme I'm hearing is just how you're asking the questions. So when you were talking about the CMEs for lab, and for our staff after Jordan, you can see the nurses become more and more aware of the ones that took care of them. So I see when kids have similar symptoms now, even in rounds, they're asking those questions when they're rounding their patients. But we had exposure to it where other hospitals may not so much. So at least, I don't know on a national level, but at least in the state of North Florida for the required CPs, maybe it needs to be nursing too. Because you're talking a lot about the phrasing and the people that are asking these questions being aware, so that might be a way to at least get in and assistant nurses or, required that way.
As well, I work on the adult side in neurology and surgery. As much as we're talking about information for children, as well making sure we include the wording that for young adults, because we had our first case of PAM was 5 years ago, a 22-year-old male. So as much as we're talking about children, we need to make sure we also speak to young adults who are also doing vigorous or other activities such as wakeboarding, diving and things like that. So I know we're talking children, but I think we need to make sure we also expand it, because on the adult side, it was our first time ever seeing one.
It can occur at any age. It's just that younger people are more likely to do the things that get them exposed.
Right, but I just want to make sure that.
That's a good point.
On our side, we had never heard of it until it was a lab tech, and also we were the first one to notice it that many years ago, and that increased our awareness on the adult side.
So the alert is for all ages. It's not divided by ages, and it's all year long. So not just for the summer in Florida.
So one idea, I'm an infectious disease doctor, and something I haven't done in my practice per se, but something to think about, which is that because we know that the description of the pathogenesis is that this is not just water exposure, as like on the skin or anywhere else. It's a very specific exposure. It's contact with the head, specifically up the nose, which is the only route by which that can get up there. So maybe it might be very helpful to even be a little more sensitive and specific and say that, did your child play in any sort of activity in which water, fresh water or those kind of water, could have potentially exposed the face or the nose, because it adds a level of awareness, but also people might start thinking of things. So, for example, the situation with the neti pot, right? That's a different route by which someone got infected through municipal water. So we're talking about kids, we're talking about fresh water and lakes and that. But if you're talking about broadening the scope, it's really exposure of that kind of water source to the nose.
I was going to say that we can't just focus on red alert because your patient denied exposure to initially.
He denied exposure to going swimming on the pond, but he was clear that he was using well water to wash the face. So we initially were thinking that his exposure was the well water that we were using to wash the face and things like that. So we said maybe, didn't really fast in the beginning because it was really, wouldn't be common, but you're true, he denied it. But that's why, what Sheila was mentioning, right now, every single sample, even if we don't give them the information for exposure, they are being more thrilled in trying to look for the amoeba. Now, when we give them the information, they will have a more alert to do it, but they're already looking every sample for it anyway. But yeah, that's true. If they deny, it's nothing that you can, nothing that you can do.
Thank you. I am a general pediatrician. And I'm so happy to be coming here, and I have been learning a lot about this. I think that each life is a precious life, priceless. And I think what we need to do here is education and action. Education in a way of people are not aware. The parents are not aware. If we have a season of flu, everybody's talking about flu. Flu is coming here, you need to get vaccines, you need to be aware. Flu publicity on radio, flu publicity and television, everywhere. Even we get these flu flyers on our office. We need to put it in there. How many kids have been dying of flu per year, and how many kids need to die because of this this parasite. So publicity, we need to work on publicity. Publicity where these amoebas are. On the lakes, so we need to put information. If there is a park over there, I think that the entrance, somebody need to go and give flyers. Hey, this is the season of this amoeba. You need to be aware that if these symptoms appear on your kids or anyone in your house, notify. Go to your physician, go to the doctors or the hospital, and let them know that you went to a lake, to a freshwater lake, or to a river. So I think this is a part of the ending of this situation.
I agree, that's very important, and that's prevention. And another workshop is dealing with that right now. We're supposed to focus on the issues about diagnosis and treatment. And so the other workshop, I think they're probably talking about it right as we speak.
Okay, so that was one part. The second part is about if we know the symptoms of meningitis or encephalitis, viral meningitis and encephalitis, and we see a patient that is getting critically ill by minute, because that's why we have been learning about this amoeba. Why don't we do an action? The majority of cases have been here in Florida, so why don't we put a protocol in the hospitals that if this is a patient who has encephalitis, viral meningitis, and is getting sick, why do we have to wait to get a lab result when we see a human being, a kid, who is getting sick, and we know these cases? Why don't we put a protocol that, hey, there is an option. Can we treat it? Let's treat it. In a way of prophylaxis. That's prophylaxis. There is a risk, there is a benefit. What will be the risk for treat this patient who is getting sick and sicker?
So you're talking about creating care paths, and we've been talking about that a little bit here. And I think a care path really does help facilitate more efficient care for a particular diagnosis. So you're talking about creating a care path for meningitis and encephalitis, which I think is a great idea. And I think that we can decide as a group whether that should be one of our main initiatives for the next year, is to, instead of just depending upon Dr. Jordan and his group here at Florida Hospital on creating a care path and then we'll get to copy it, how about if we collaborate, help him with it, make that care path, that then we could figure out some way of trying to disseminate it to at least the hospitals in Florida, because we have a lot of contacts here within the state. What do you all think about that? I saw a few heads nodding.
How hard is it to get a hospital or maybe like regional Lakeland? How hard is it? Who actually drives that in that facility?
So the question is, how hard is it to do a care path and implement it?
Care pathway and to actually get it implemented where it is used.
It can be hard. It first requires some sort of recognition at the administrative level of the need, or at least on the medical level. Then you need a group put together who are willing to volunteer their time to research the literature and come up with what should be the main components of proper care for that care path and how it's going to be implemented. So in the case of PAM, we would need to bring in people from the lab, from the emergency center, the hospitalist service, infectious diseases, anyone that we think might have an important say of how potential PAM patients should be cared for. It often has to be presented in different committees so that the groups that weren't in the original care path committee hear about. That may take 1 or 2 months. Along the way, you're getting buy-in from administrators, and hopefully there's an administrator on the original care path committee, or the care path committee reports to another committee that has an administrator on it. I think if you get a lot of people working hard at it, it can be done in a few months. Then you have to figure out how to implement it, whether if it involves creating a computer alert, well then you have to talk to the director of information management. on how they're going to add that alert. Some alerts can be done very quickly, some can't be done for 2 years until the next software upgrade. But that's part of the Care Path Development Committee as to what can we do fast and getting all the right people involved in doing that.
Now, we've been talking about starting treatment right away, very quickly, with Steve and with Sheldon. And the problem that we have, or at least, from our perspective, is that we believe that if we're going to start treatment, it has to be everything together. Because that's what we know that the survivors' cases have received. And if you see, it's pretty intense treatment. You're putting someone on pentobarbital coma, you're intubating, you're putting a device on the brain, you're giving hypothermia, we can give you heart failure, renal failure, liver failure. You're putting all these toxic medication that interact with them that will give you more toxicity. So you're exposing a kid to a lot of surgical interventions and a lot of potential harm based just on empiric treatment without having at least some clue on the diagnosis that that's what is going on. So that's what we are afraid to. Every kid that comes to the AD door with symptoms and signs of meningitis, with an abnormal CSF, with negative testing for bacteria, maybe negative testing with viral infection with the new PCRs, say, oh, if this is negative, this has to be amoeba, we haven't seen it, but let's start treatment. Because the treatment is extremely, extremely, extremely intense, and it has a lot of side effects. And a lot of them really harm. So you see, for example, with this case that we have right now, he has neuropathy that we cannot explain, because every single imaging testing is negative. But he does have neuropathy. He has pain neuropathy, poor sensation, clonus, Babinski, but we cannot say why he got it. The medications don't give you that. The MRI is completely negative. Hypothermia doesn't give you that. And as far as we know, amoeba doesn't go to the spine, just to the brain. He went on almost 4 days of hemodialysis. Every single hemodialysis circuit clotted on him. So it's a lot of, we made a lot of harm trying to save him. So the question is, we're going to put every single kid that comes through an ED with negative testing through all this because we think there is amoeba without confirmation, and that's what we struggle, because it's just too difficult to do it.
But that's my point.
Well, I'm sorry, I need to cut you off because we need to finish our agenda, but I understand your point, and I think that's what the Care Path will fix, that it will help us make sure that the Care Path will address who do we need to consider for the testing and treatment.
And also, if that patient needs that treatment, why are we putting this patient on coma? What will be the benefits?
Right. It's not just putting them in a coma, you got to cool them off, you got to put a bolt into the brain. So yeah, there's a lot involved in proper care for this after the diagnosis is highly suspected or confirmed. And that's why we don't want to jump to doing that for every child with a headache. I'd like to move on to the agenda because we only have 13 minutes before noon, and people usually don't like to have their lunch delayed. So, and I'd like to summarize a couple of points. The next step is treatment, which Dr. Jordan was just talking about. The standard protocol, I think, we pretty much accept in the infectious disease and critical care community, that we're going to copy that protocol that was published last year and that you all implemented so well. Is there a need to disseminate the protocol is something I had on the agenda. But Dr. Sharon mentioned that in his presentation this morning, that he did that by publishing an article reminding people what the protocol was, and I think in the Journal of American Medical Association. There may be opportunities to do that more and more, but I think people will usually look up the protocol or ask their infectious disease specialists. So maybe the need to disseminate the treatment protocol is not as important as the diagnostic care path, in my opinion.
I think we're talking yesterday about it. I think one thing that we need to do is that the ED providers know that the disease exists. And that as soon as they get it or they suspect it, they have to call the ICU and the infectious diseases team.
So in the emergency department, when someone comes with a heart attack, we call it a code STEM here in Florida Hospital. Stroke, code gray, we call it. Those are all time-sensitive conditions. And we do have protocols for that. So
trying to think about something for this. Is this something that we need to develop something like that when this does come to light where you push one button and everybody's activated? It's a thought we were talking about, and that would allow the physicians just to say, hey, we have this condition. Now we just go down the pathway of this, and even if it's just calling immediately the ID doctor, the interventionalist, and they take it from there, that's a big deal. Or the pathologist, if you can get in the car and start driving to the hospital to get this process started, is a win. Because it is challenging because of the way the computer system world works. And even we started talking a little before, how do you disseminate this nationally? Do you bring what we develop or come out that might work to actually the companies themselves who develop the products? Go to
the electronic medical record
like
companies.
exactly, for like Cerner, Epic. You go bring to them because they're the ones who do the updates. They're the ones that disseminate the new products. They're the ones and that actually goes nationwide, not just locally. So that's just a consideration that's going to take, that's what this discussion's about. Yes.
I just had a question, being an ER nurse. We have kids for RSI, we have kids for this, that, and the other. With those antibiotics needing to be given in a timely fashion, would it be possible to fashion a kit? Because it could take us half an hour, 45 minutes sometimes.
So we're both from pharmacy, and I'm one of the new ID specialists at the adult hospital. But those drugs wouldn't be able to be available in a kit because of the way they need to be compounded. Great thought. But to piggyback off some of the conversation that's going, I think that having an alert, having a lot of these.
The other problem is with children, we have to dose drugs based on their weight.
Yes.
So the dose is different for every kid.
Yes. But I feel something that Mike and I have been talking about is we have so many great ideas, but not every hospital, not every place that these parents are taking their children or that the EMS are taking them are able to do these procedures, have the appropriate people available. So something that needs to be considered is with the EMS education, where are they taking these patients? Not everybody has the drugs, the neurosurgeons, the capabilities of doing an LP, so that's something else to consider while we're doing the education and things like that. But the pharmacy, I think, component can respond to things very quickly, but again, a kit may not be the best approach because of the specific dosing and compounding.
That's a great point about EMS taking them to the right place. And I'm glad you commented about the drugs because that's the last item on the agenda, which is miltefosine, the drug that was harder to get because we had to get it from the CDC, but now is now available commercially. I think a goal would be to have it stocked in more hospital pharmacies. It comes in a pill form, and I know that at All Children's Hospital in St. Petersburg, where I work, our pharmacy director recently agreed to stock it. And the manufacturer has made it very easy for them to stock it so that even if it expires before they ever use it, they can return it for a refund. So if we can, maybe we should we target at least the children's hospitals across the state carry that in their pharmacies?
Yeah, so what I was going to say is maybe, figure out which children's hospitals actually have all the staff we need to take care of these patients. Disseminate this information to the community center so I can say, we work close, for instance, with Lakeland, so we get a lot of patients that come from there because they may not have the capabilities. So each individual hospital who has ties to the community hospitals, make sure that we're educating them that this is, these are the 5-10 hospitals in the state of Florida that have the protocol, have everything on site. So if you guys are suspecting this is what you should be doing. Contact us, just like we have trauma centers. That's where you want to go, right? But when your child is sick, I'm going to pick him up and I'm going to take him to the nearest hospital. I'm not going to drive where it is. So I think we definitely need to figure out a way to talk to our community hospital so that we can help them provide the best care and bring them to us who can have everything on site.
Dr. Cadilla, do you think the main things we should target are hospitals that have neurosurgery, critical care, and ID?
So what I was thinking, what we were talking, so we've already started talking about it. So we need to get ED, PICU, neurosurge, micro, and ID, right? And then as long as we have those core services and our pharmacy is able to stock it, I think that's going to be.
Is this something where hospitals don't have those resources, that they still, obviously, I'm not at a hospital that does not have resources, we transfer, obviously, that's our goal. So when you transfer the patient, you talk to the specialist on board, you're saying, hey, this is my suspicion. Gosh, some places could be an hour or two delay getting to you, 3-hour delay getting to you. So is that something you contact the ID doctors and say, hey, should we start implementing the medication like azithromycin, the ones that are not going to take time?
Yeah, we get a lot of calls from transfer centers.
And so,
and there are many things that can begin
before.
Actually, all the medications like tafazine are readily and easily
available. I mean, I give azithromycin all the time to patients. You know, I'm really not giving antidepressant, but fluconazole, rifampin. But those are medications that are available usually at most of the hospitals, I believe.
You mentioned about making sure the hospitals have it stocked. That's great, you know, with the case in Houston, the hospital had the medicine in there, nobody knew. Only a few people know. So, you want to have it in there, but you got to educate the staff, and then the pharmacy was not open. So there has to be somewhere to be able to get to it. It wasn't a 24-hour pharmacy. Right. So that, just having it there is the first step is great. But being able to know it's there and get to it, that is critical as well. Because the medicine, is the safer, but the beginning part of it, to get to that medicine, has to happen first, and then be able to get to it.
So, Dr. McGraw,
Your pathway, though, is identifying that the product is not only in the hospital, but in the proper place, so that when the point comes for it to be implemented in the care pathway, it's accessible.
Would I recommend that, like some of the points we're talking about today are, one, obviously education, and then our second point is the care pathway, and the third point would possibly be, obviously, trying to disseminate Tifson. That might be some options.
Those are some of the main things I've recorded here as things for us to decide right now. We have 4 minutes left. We need to pick 1 to 3 initiatives that we can work on over the course of the next year and hopefully accomplish by the time of the next Amoeba Summit. I think the specific ones are to convene a group of volunteers to create a care path. Another one is to try to identify Florida hospitals that should stock miltefosine in their hospital pharmacy. And the other one is whether to integrate education about PAM into medical relicensure for different types of medical specialists.
Yeah, for sure the lab should have some kind of ongoing training so that the technicians know about it and know how to recognize it, how to look for it.
We could even integrate that into a care path, that if the hospital is going to adopt the care path we create, that part of it is education of the laboratory staff on... Yeah, so that maybe we'll put that in with the care path goal.
You could also tie in the care path the question. That would
yes, exactly. That's
the
number one.
The ultimate.
I think not only the lab technicians, but the lab physicians.
Yes.
And also the clinicians, clearly mentioned that their desire to training as well.
Right.
And I have one last question, and I apologize. Sure. But when you talk about miltefosine, right, because this is all so new and we're just starting to get some successes, as a parent, if I'd have known there was even a potential drug that had little to no side effects that we could have started Jordan on, as a parent, I would have made that decision. So from the miltefosine side, why wouldn't we have it in every hospital? Number one, Todd is willing to put it in every hospital at no charge to the hospital or the pharmacies, at no charge unless you utilize the products. So why wouldn't you have it everywhere, number one? Number two, because these are new grounds we're treading here, why couldn't that drug be given
on the initial onset of possibly having an amoebic case if there's very few side effects.
That's a good point. So now I'm wondering, what's the most efficient way of contacting all hospital pharmacy directors across the state
We've been
to
working on that.
ask them to stock it and give them the reason why? We could maybe ask our pharmacists, is there a network that can be used for that?
Pharmacist like to answer that question?
Yeah, there is a network. Hi, yes, there is a network, and if you want to expand that outside of Florida, you could also perhaps use the Children's Hospital Association, which most children's hospitals are members of, to spread the word, because chances are, if there were a case, they would line up at one of those hospitals because they're the ones most equipped with the resources and with the critical care, laboratory services, intensive care, to treat these patients. But yeah, I know within our system, I have raised the question and have made awareness. It's still going to end up being a regional decision, I think.
Do we know enough about the drug? To know that it would be a good thing to give that to somebody right away if you're not then going to do all the visits that you did. So if there's 2 hours that go from some community hospital to a center where they can do treatment, is it really a benefit to the patient to start the drug? Similar to like other types of meningitis like pneumococcal influenza, where we knew we could keep them from having some hearing loss by giving steroids at the same time. Do we have to do all the treatments, or just getting in that drug quick, is that the best thing?
There is no data for monotherapy, and that's the problem. And I guess one dose of medication is not going to give you side effects. The medication does increase your creatinine from your baseline 3 times, so it does a high risk of nephrotoxicity. But for a long term, one dose is not going to give you nephrotoxicity. But data on monotherapy, there is not. So it's impossible to tell you if giving the medication is going to make any clinical difference. There is no way to know.
The last thing we need to do is assign a spokesperson to give a report on our conclusions at 1 o'clock. Okay. I'll do it. Twisted my arm.
Can you just recap one more time what we're going to present?
I think that what we'll present is to convene a working group to create a care path that could be disseminated at least to hospitals in Florida and maybe eventually nationwide. And to contact our pharmacy colleagues about how to get miltefosine in all the hospitals in Florida.
Okay, we start there, sure.
We were initially thinking of targeting just the children's hospitals, but I think it's a good idea. Why not?
Ask.
Yeah.
Absolutely.
And those are the main two, because I think a lot got built into the care path creation.
There was,
education was part of the care path. Yeah.
Okay.
So those two sound good?
I just have a question about, there is another part of the body that this amoeba can be detected in a way to find another type of way to diagnose. And a lab test means if this amoeba go through the nose, you just go directly to the brain, or can we find another part of the body that the test can be directed to that part?
The only thing I've ever seen is prospective studies looking for nasal carriage of amoeba in Africa, where they went ahead, found a village where a child died of amoebic encephalitis. They went ahead and did nasal irrigation of a bunch of asymptomatic kids and detected amoeba in some of them, and they never got sick. But that is not going to be as useful as checking the CSF, I think.
Now, there is a case case report of a patient that died from amoeba, and the organs were used for transplant. And the donor, the recipient so far as we know, hasn't developed any type of symptoms of amoeba. So you may say that the amoeba didn't disseminate it to the body, just stayed in the brain.
That was my son. So, but they did find amoeba in his heart.
Yeah, but the recipient,
Well, they couldn't use his heart for transplant, but there were amoeba in the heart and lung. So, I wonder about serum PCR testing.
You could probably do serum PCR. I suspect it would be less sensitive than the CSF. Huh? Oh, is he here?
Hey,
oh, there he is.
Do you think you can do blood PCR for amoeba? Do you think that you actually go systemically to test by molecular testing or not?
Yeah, we have tested blood for but sometimes it's positive, but only when the patient is very badly infected. Then we could detect amoeba DNA in the blood. For example, in the New York case, the recent one, we could find DNA even in the blood. But this is not like reproducible. Well, not even reproducible. This is not true for all the cases. In some cases, the blood is clean. We never found any amoeba. So in some cases, it's positive. It's possible to detect it in the blood, but not in every case.
Thanks everybody for your input. I think we'll conclude the session.
Thank you.